We have learned a lot about PH-like ALL over the last decade, and I think what remains surprising to me is how very clinically and genetically heterogeneous it is, and this has required a very complicated genetic testing algorithm, at least here in North America, to try to figure out who these patients are. I think as we have spent a long time doing preclinical and now clinical research to identify these patients, we've been able to simplify the testing a little bit. And in a recent review that I wrote with Dr. Rick Harvey at the University of New Mexico, we've detailed a nice algorithm to what we think is a clinically practical approach to identifying patients, such that they might be identified within the first 2 weeks of starting chemotherapy and their initial diagnosis for potential intervention with tyrosine kinase inhibitor-based strategies. So in this review paper, we detail some of the work that's been done to identify the kinase-activated gene expression signature of patients with PH-like ALL. Certainly in North America, we use something called the low-density microarray, which helps to identify this kinase-activated signature. This is not a completely specific diagnostic test for patients with PH-like ALL who really require further specific molecular characterization. But for us in pediatric oncology, it's been a very helpful screening tool to help rule out the 80 to 85% of patients who do not have PH-like ALL, and then really to focus the much more detailed genetic testing on those 15 to 20% of patients who have the activated kinase signature. This has not been an approach that's been used in Europe, and it seems to be a little bit more exclusive to North American clinical trials. We've also learned that flow cytometry immunophenotyping is very helpful. And in fact, for patients who have the most common type of PH-like ALL with CRLF2 rearrangements or cytokine receptor-like factor 2 rearrangements, these patients can actually be identified by diagnostic flow cytometry with increased surface staining for the thymic stromal lymphopoietin receptor, or TSLPR, that's encoded by the CRLF2 gene. This seems to be quite a sensitive and specific test, and this is an answer that we often can find within 24 hours of a patient being diagnosed with ALL. And that can be an important clue that those patients with increased TSLPR surface expression by flow cytometry need further genetic characterization to identify if and which specific CRLF2 rearrangement is present. A third assay that we review in the paper is FISH, fluorescence in situ hybridization. We now know that many aberrant signals can be picked up by routine clinical FISH, particularly for those ABL class alterations involving ABL1, ABL2, CSF1R, PDGFR beta, as well as FISH probes that are now available for CRLF2 and JAK2. So it is possible through routine clinical cytogenetics, if you have a detailed FISH panel, to also identify patients with potential PH-like ALL who have disruption of one of these genes that is usually involved as the 3' partner within PH-like ALL kinase fusions. And this can also be a rapid clue that these are patients who need more detailed downstream genetic analysis to identify which specific fusion. But we think having FISH positivity may be sufficient to intervene during the first month of induction chemotherapy with addition of a relevant tyrosine kinase inhibitor that matches with that gene. And then finally, we review some of the more detailed sequencing and molecular analyses that are needed to really put a fine point on which PH-like fusion might exist in the patient. And these are things like fusion analyses or RNA sequencing. There are a wide variety now of clinically available and much more affordable genetic sequencing platforms that can be very helpful, both at an RNA level as well as a DNA-based next-generation sequencing level to identify point mutations that are sometimes associated with PH-like ALL. And these platforms are also able to detect some of the sentinel transcription factor deletions that are common to co-occur in PH-like ALL, including things like deletions of Icaros, PAX5, CDKN2A, et cetera. So even though it's a very complicated process, I think, to identify patients with PH-like ALL, I think we've really identified some very simple and practical methods that are routinely available in everyone's clinical hematopathology lab that can give clues about patients with PH-like ALL who might then need that more detailed testing.